to our next speaker on a perspective on how data-led decision-making is being applied in the frontline healthcare delivery. Dr. Gareth Forbes is GP partner, clinical lead, and a director at Derwentside Healthcare GP Federation, an informatics lead for primary care research in the North East and North Cumbria. Welcome, Gareth. You're going to tell us about using data to drive improvement in real-world primary care. Over to you.
Thank you, David. So the Clinical Digital Resources Collaborative is an NHS-owned collaboration which provides IT resources for UK health and social care organisations, which are free at the point of access. Can I have the next slide, please? So what we do, data analysis is only going to have any impact if it leads to change, as some of the other speakers have said. And so much of healthcare data analysis actually makes very little difference to patient care. So CDRC resources concentrate on using data to maximise the impact of 4 points of contact with patients. So that's opportunistic care, such as the patient presenting with a cough who might need a blood pressure check. Routine care, that's making sure, for example, that long-term condition reviews cover all the most beneficial interventions. Real-time change, for example, entry of a new chronic kidney disease diagnosis in the record of a patient might prompt an alert explaining their blood pressure target has changed. And systematic targeting, so that's finding all the patients who might benefit from a particular intervention and targeting them specifically. And that targeting might be subdivided into different ways, such as looking at those at highest risk, looking at those with the highest number of interventions, or looking at those who are at risk of inequality or have vulnerabilities. Next slide, please. IT tools are only going to lead to any change if the stakeholders involved are willing to use them. So it's critical that we understand the motivations, the drivers, and the barriers to using those resources. I've shown some motivations on the left-hand side of this slide. As our primary care is buckling under an unsustainable workload and widespread burnout, we can rely less and less on the drivers at the top of this list, and financial drivers become much more important. On the right, I've listed some of the barriers to uptake. In particular, it's the use of multiple overlapping new systems or systems that trigger too often are very off-putting and lead to lots of resistance to uptake. If you really want to watch the eyes of a frontline primary care clinician glaze over, tell them about a new swanky dashboard or toolkit which is going to solve all of their problems. Next slide, please. So here's some big data from County Durham. That's a little over 500,000 people. 1.3% of our population have had a home blood pressure more than 135/85. By definition, they have hypertension, but they haven't been coded as having hypertension in their record. That means it's very unlikely they'll be getting the relevant follow-up and the checks they need. 9% of that same population have got their last blood pressure reading being over the hypertension threshold, again, not on the hypertension register. And a large proportion of those patients will have undiagnosed hypertension. Of the people who have a long-term condition needing a blood pressure check, around 6% are at least 3 months overdue, and 30% don't have adequate blood pressure control. Hypertension is a condition with no requirement for expensive, difficult tests. We've got highly effective, very cheap, generally well-tolerated treatment which prevents conditions associated with long-term disability such as stroke, heart failure, chronic kidney disease and dementia. But it does rely on regular patient-clinician interaction and patient understanding and trust. Financial incentives to detect and manage hypertension in primary care are minimal or absent. Next slide, please. So here are some examples of CDRC resources to help with hypertension detection and management. At the top is a prompt to help people realise that somebody being seen opportunistically probably needs a blood pressure check. Below is a real-time change prompt, which has followed a clinical entry in the clinical record. Next slide, please. This screenshot shows some resources for systematic targeting. So at the top is a list of, or a link to patients who might not be engaging with their care. They're not coming for their annual reviews. They're not taking their medication. And these patients might be best targeted by a care coordinator or a social prescribing link worker. Below are patients whose blood pressure control is suboptimal. And because the numbers are so daunting, this is subdivided into manageable chunks, such as looking at how far off adequate control they are, or who are the patients who are at risk of inequalities who might need additional support or a different approach. Next slide, please. This slide shows people who've potentially got undiagnosed hypertension. So the last blood pressure is raised, but they're not diagnosed with hypertension. And again, the numbers are really large for most practices, so we can split that into manageable groups to prioritize, such as those with the highest blood pressure, or those who are eligible for an NHS health check, or those who have other social or other inequalities issues. And from screens like this, with a few clicks, we can send patients electronic invitations so they can book themselves into appointments, or send us their own blood pressure readings, or give them recommendations to visit a local pharmacy to get a blood pressure check. Next slide, please. So the general approach is summarized here that can be applied to all the resources that we build for targeting. You subdivide that group into different kinds of intervention, and then you make sure that you're using the right professionals to approach those patients. And then specifically, we're looking at people with a wide range of risks of inequality or vulnerability that we can target in a different way or use a different approach. Next slide, please. An even better model is to get away from a single disease issue. So what we can do here is stop looking at individual healthcare needs like hypertension. We can rank patients based on all the interventions they might benefit from. So that might include medication or lifestyle interventions, monitoring and safety, screening and vaccinations. We can then focus on those with the highest number of potential interventions, directing patients to the most appropriate healthcare professional, while directing additional resource to those likely to have additional needs who'd benefit from a different approach. Next slide, please. So finally, to keep all the data people happy, here's some data looking at outcomes of this sort of approach in my primary care network. That's Derwentsside, which is about 95,000 patients. The same issues that I've described around hypertension apply to lots of other risk factors, such as blood sugar, cholesterol control, obesity, chronic kidney disease, and many others. So here I've shown the prevalence data for some of these key risk factors. The top line in most of these graphs, the blue one, is my PCN. The red line's the rest of the county that we're in, and the longer bottom lines are the national figures. And you can see that Derwentsside PCN has very high and rising prevalence of these risk factors compared with our neighbours. But our coronary heart disease prevalence is lower than our neighbours and is falling faster. So in conclusion, I'd like to recommend that we concentrate on using data to drive investment in at the coalface pragmatic delivery of care. This means investing in people, interactions and relationships and not dashboards. In particular, we need to remember that many of the things that we should be measuring, such as patient priorities, fears and wishes, are very difficult, if not impossible, to put on a dashboard. Thank you.
Thank you very much, Gareth. It's a fantastic presentation. Before I move on, when you look ahead in the context of everything that you've just shared with us, how do you see the role of data evolving in general practice, particularly as you've illustrated, patient needs grow more complex and resources are ever more constrained?
So my fear is that what will happen is that we'll just throw more money at ever more complicated data analysis and producing data that we don't do anything with. What I hope we do is we direct those resources much more to how are we going to use data to drive improvements in care and intervention.
Thank you. And what challenges do you have in terms of patients moving through different parts of the healthcare system in and out of secondary care and so on? How do you think there's scope for improvement there?
That's one of our biggest challenges. The transfer of information between primary and secondary care. Some of that is about different priorities. Secondary and primary care often have different priorities, and the clinicians discharging someone from the ward or from the outpatient clinic don't necessarily know what our priorities are and vice versa. But there is a real problem in the transfer of not just of information, but of narrative when people are moving from primary care to secondary care. especially about what's most important to the patient, as opposed to just slavishly following guidelines.
Yeah. Thank you. Thanks, Gareth.